I'm Nancy Hart Wicker. I'm the Physician Medical Director here at Hospice and Palliative Care, the Piedmont in Greenwood, South Carolina. This is what I love. This is also what I'm specially trained to do. So I did an extra year of training specifically in hospice and palliative care, and then sat for a certification exam, and I'm board certified in hospice and palliative care. And I think the benefit of that is just, if you have more complicated symptoms, more complicated issues that may come up, I've been trained specifically on how to handle that. If you ask most people, if you knew you were dying, where would you want to be? What would you want that to look like? The vast majority of people will say, I want to be at home or in a home-like setting, and I want to be surrounded by my family, and I want to be comfortable and pain-free. And I think that's where hospice comes in. Hospice is a type of care. It's not a place. And so there's a lot to consider, I think, in choosing a hospice organization. But one thing that I think is really important is what are their options outside of home care that are available to you. Our organization has the Hospice House. It's the only hospice inpatient unit in Greenwood and the surrounding counties outside of Lawrence. Lawrence County also has one. The nice thing about being with a hospice organization with an inpatient unit or with a hospice house is the ease of going back and forth. So we have people who come into the hospice house and then go home once they get their symptoms managed. We have people who are in the home and they have a need that exceeds what can be done at home, and then they come into the inpatient unit. Prior to the start of hospice as a kind of formalized Medicare program, people were dying more and more in the hospital setting. It's not as homey, you can't see the outside, you can't have unlimited visitation. Many of them were not getting the expert symptom management, so then control of their pain, their shortness of breath, their restlessness, those sorts of things that can be provided through hospice. And so when they created hospice services, that's basically bringing all that expert care, all those expert services into the home setting. So people are at home with people they love, with the support for the family to provide that care in the home, and then with the expert services to make sure that they're not having pain, shortness of breath, or any of those symptoms involved. So I think a lot of people kind of feel like a hospice is a hospice is a hospice, right? And there's not really a big difference. There can be a huge difference. People don't know the questions to ask. How often is the nurse going to be visiting you? How often is the social worker going to be visiting? Again, what is your inpatient option? Who is your doctor? Are they going to be able to see me? Those sorts of things, I think people don't even really know to ask that. Our organization, on a stable patient, a patient who's not really having any issues, is typically seen about twice a week by the nurse. They can see them more often than that. If they're having, again, a symptom, we will always follow up. Certainly our patients who are active or having a symptom needs, oftentimes they're seen every day. Sometimes if it's really bad, they may be seen twice a day or more than once a day. Hospice is a 24-hour operation. That's a huge benefit to the patients who are used to, it's a Saturday morning, and I'm having a problem, my only option is to go to the emergency department. Whereas under hospice services, they can call our hospice nurse, who will either give them advice over the phone or they'll pay a visit. Our nurses do them very regularly. It's in the middle of the night, it's on the weekend, they're having a problem, our nurses will go and visit them and address it then. There's not much more important than choosing somebody caring and qualified to take care of your loved one at end of life. And so you certainly want the person who's doing your palliative care to have knowledge about it, training about it, and I would think you'd want someone who had a passion in that particular area. Where does your nurse on call live, right? Because having an on-call nurse is great, but if they live, really far away, there might be a delay in receiving the care you need. If they're having an issue and they need to go to the inpatient, how often have y'all done that? What's the delay time for that? How are you able to facilitate that in the off hours? When it's your loved one, you want to be able to call someone who's going to care and know what they're doing and respond in a prompt manner. Hospice Medicare patients, or hospice patients in general, can opt to keep their attending as their primary care physician, their oncologist, whoever would agree to be that. They can still be their attending physician, but then on top of that, they will have a hospice medical director. Every hospice has to have it, a physician who's the director over hospice services. But my question would be, who are they? What's their practice? And how often would they be seeing you? What's kind of the process for evaluation? Because I think that's what varies kind of hospice to hospice. The other thing I think is important is how often do they see patients? So in addition to seeing our hospice house patients every day, I do home visits, which is actually my favorite part of my job. I love to do it. I drive all around and see patients in their homes. You learn a lot about someone kind of in their home environment. So I would want to know as a family member if that was an option to have a home visit if we were having trouble at home. We work very closely with palliative care. So if a patient is under palliative care and they're receiving the services, but they require more assistance in the home, or they become more appropriate for hospice services, it's a very easy transition because we work very closely with them. We were doing just inpatient services. So if someone's in the hospital, they have either a symptom need, again, uncontrolled pain, something like that, or they were kind of having to make some decisions. Our inpatient team would see the patient, kind of help with that. But then we were noticing, well, it's great, all well and good to have it in the hospital, but like, what if somebody actually needs some services outside the hospital? So for a long time, I think about 10 years, we've been doing outpatient, so clinic-based palliative care for cancer center patients. So we've been teaming up with the oncologists there to help take care of their patients and any of their palliative care needs. So then we're like, that's great. We can see the patients in the hospital. We can see them in the clinic who have a cancer diagnosis, but what about all the other patients that have another serious illness, heart failure, COPD, dementia, things like that? They have needs too. So we were really excited. A little over 2 years ago, we opened our palliative care outpatient clinic and have been able to see patients there who don't necessarily have a cancer diagnosis, but have other serious illness, and we can serve them there. Then we were saying, great, we can see them in the hospital, we can see them in the clinic, but there's certainly a subset of patients who cannot really get to another appointment. They may be homebound, transportation may be very challenging, and so we probably our most rapidly growing area within palliative care is our home-based program. So we have nurse practitioners that go into the homes and see the patients there and able to serve them. That's really big because a lot of these patients, once they become really, really ill, it's very challenging to get them to another appointment. And again, you really learn a lot about a patient in their home. A lot of times we prescribe different therapies or medications and we wonder why someone's not compliant with them, and then you go into their home and you maybe learn some things that might make it challenging to comply with those. So as you can see, we can basically serve any patient along the spectrum of need, right? Whether they have a cancer diagnosis, a non-cancer diagnosis, whether they need to be seen in the hospital, the clinic, or at home, we can kind of see any patient along that spectrum. The question of how to choose a hospice is there's been an attempt to formalize that. There's a website, www.cms.gov, and they have scores for different kind of quality measures. And these are things that are really important. How quick were my nurses to respond to my needs? How quick were they to get my pain under control? How many visits was my loved one given from not only the nurses, but the other interdisciplinary team members? Kind of just overall satisfaction with the hospice. And it's ranked, they'll give a percentage of the hospice, and then they'll give a nationwide percentage. And I'm very proud of our organization. It certainly has to do with our team as a whole, but we are above the national average on every single measure that is on that survey. Any hospice that's certified in the country should be on there, and you should be able to look that up. If all else fails and you kind of don't know what to do next, I think you can always ask your trusted primary care physician, your trusted oncologist, and see who they may recommend. One thing I like about our organization, and I think is a benefit, is that we are locally owned, run, operated, community-based. We're also a nonprofit hospice, which allows us to serve any patient regardless of their payer source. That's why I like working for them, because I want to be able to serve all patients. The nonprofit thing I think really helps because we can serve all patients. I think the locally owned, run, and operated is helpful because you have people in charge making decisions who live in the community, care about our community, and are invested here as well. I do always say that, you certainly don't want me to be your doctor because you're probably going through a hard time if I'm your doctor. But if you need someone to give this type of care, I do think that we provide really good, very competent, very compassionate, holistic hospice and palliative care. The people who really love their jobs and care about what they do stay here and stay here a long time. You'll notice that our leadership, many of them have been here for a very long time. But you don't really last here long if it's just a job to you. And it's not a job to us, it's a calling, it's a ministry, it's all those things. So I think you would want the person caring for you to really love what they do, know what they're doing, be competent, but also love what they're doing. And I think that's how we look at it here.